whole and the specialist nurses do. We've not rehearsed this at all. That's why I was like,
so we just wanted to ask the question, what do we do as IBD nurses, apart from walk through a cup of tea, back and forth to the printer, and whinge about the temperature in the conservatory? So, any ideas?
Don't do that for me.
morning, Stephen.
Morning.
So, yeah.
What do you guys think we do?
You're going to have to contact, aren't you, people that are suffering with this condition?
Exactly. Yeah. We do an array of things. We're sort of jack of all trades, semi-master of some of them. So we both run IBD nurse-led clinics. I do 4, Sarah does 2, and that's mirrored over at DGH as well with Jane and Kim. Some of you may have met Jane before. I don't think any of you would have met Kim, our biologics nurse over there, but you might see them breezing in and out of endoscopy if you're ever there. So yeah, we do nurse-led clinics.
2 face-to-face, less sort of telephone, but hopefully we'll be getting more face-to-face. And I'll probably increase mine as my knowledge gets better.
And we see new patients, we routinely see follow-up patients. So one thing to remember is once you guys have diagnosed IBD, and predominantly it will come from endoscopy, they are then put onto our caseload and they are never discharged. So they are lifetime patients of ours. So as you can imagine, our caseload never gets smaller, it's just exponentially getting bigger with the rise in diagnosis. And some of you that have been here for many years have probably seen how getting more and more diagnosis of IBD coming through endoscopy. And whether that's because we're now better at seeing it, GPs are better at sort of sending patients in, I don't really know. But
is it that it is becoming more prevalent?
I think there's some of that. I also think there's an older generation, because we do get, so classical age for diagnosis of IBD is between the ages of 18 to 30. It's generally first onset. However, as Dawn says, we're seeing a lot older patients that are coming through. Now, my personal theory is that a lot of these patients, when you go through their history with them and you say, have you ever had, before this, how have your bowels been throughout your life? The majority of them will say, well, I've had blips, but I never thought to bother anyone. And as soon as I've sort of thought I should go to the GP, it settled down again. And it's this sort of shut up and put up culture. Well, I didn't want to bother the GP. And, you know, it's about your bowels. There is still taboo around your bodily functions, especially your bowels. So I think a lot of people put off going to the GP for a very long time. I'm also terrified of the other thing that it could be when, you know, anyone that starts bleeding rectally, I can almost guarantee you, you know, the first thing that's going to come to their head is, oh my God, I've got cancer. So, you know, a lot of patients will put it off, and then the ones.
So we partake in weekly MDMs with consultants, nurses, surgeons have their input, and also meet once a month with rheumatology, because our patients sometimes go hand in hand with arthritis. There's a big link
And
there.
you're all more than welcome if you're ever free. It's all on Teams. So if anyone wants an invite to sit in on our MDM, just ask and we'll send an invite out, and you can come and see what we chat about and how we discuss our cases one by one.
So a lot of the time is liaising GPs or trying to get through to the GPs, really. Just shared care with them. So if ever we want to, they're always always emailing the GP to liaise with that bloods and that sort of thing.
Some are better than others.
Do you find that their knowledge around it is getting better as well? Or not
Some and
necessarily?
some. It is slightly. It's getting there. They're much more aware of tests that you can do. We did traditionally see, you know, a lot of patients, when you ask them on the table before you put the scope in, they say, I've been to the GP 6 times about this, especially the younger ones. You know, this has been going on for a year and no one's done anything about it. I've been told it's IBS. That's a very common one. Been told it's IBS for the last 5 years, and no one's ever done a PR. No one's ever put them in for a colonoscopy. But more to the point, they've never done a fecal calprotectin, which is the simplest, easiest way. And we'll get, if that's elevated, they will get a direct referral into gastro. and then we can start investigations to get them diagnosed.
And they almost come here at the end of their tether, don't
Yeah,
they?
absolutely
Don't know
they
what
do.
else to do.
Yeah.
Most
Yeah.
of them,
Yeah.
Well, quite a few years, many years ago, we had a young girl, 23-year-old, coming in for colonoscopy. She'd been going to her GP for 18 months with problems in the GP, getting PVD. Eventually she went and it was a local GP. Sent her up there, she got a huge tumour that was infiltrated everywhere. You couldn't do anything.
And they
She'd
see,
been ignored for 18
because she was
months.
young, you know,
Yeah.
because of IBS, a bit stressed, are you know. That was a narrative that I think still happens, but I think it is getting better because we now readily have available calprotectin testing, which is a very easy, quick way to, you know, if your calprotectin is very low. But again, that can be misleading. It could just mean that they're stable at that point. Their IBD isn't flaring because they've come out of a flare. But, you know,
Is that a blood test?
stool test. Yeah, stool test. So it's a specific marker for inflammation in the bowel.
What will it see in that? You know,
Elevated calprotectin, which is, Stephen, are you there? It's a protein, isn't it? Yeah, but
That's right. It's a kind of inflammatory kind of protein, I guess is the best way to describe it. So when the bowel gets angry, it releases it. You know, like they do the troponins for heart attack. So I guess a similar principle. It normally gets released when there's damage.
there's that. However, again, you know, there are nuances. If patients are on any kind of non-steroidal anti-inflammatories, that can falsely elevate it, which is why I think in your pre-screening you ask if people are on NSAIDs, don't you?
We do.
Like, yeah. So yeah, that can falsely elevate it. So sometimes you'll get a false positive if someone's necking ibuprofen day after day for their stomach pain, which is probably making their pain worse. Yeah, so there's that caveat with it.
Okay, so we also assess and counsel patients. That can be either as an inpatient, if someone's coming for a flare up, we visit them and sort of talk through what's going on and sort of tell them sort of what the plan is for them, and also on the telephone. So it's quite hard to assess and without seeing somebody, so you're going by how they're feeling in themselves and sort of regular contact. And yeah, if they don't respond to treatment, then unfortunately you have to bring them into hospital. So it's yeah, getting quite a responsibility really to recognise all the signs and symptoms of a deteriorating patient. So we do repeat prescriptions for our biologic patients, which isn't just like you get a GP repeat prescription. We have to check that they've had 3 monthly bloods. We have to check that they've got appointments in the system, time in the system, so that they're monitored regularly. And then we do a big form, and it goes off to the doctor has to sign it, and then it goes up to pharmacy, and then it goes to our company called Healthcare at Home, and they release the drugs because it's expensive and it's obviously high risk. So it's quite a long.
So when you're
process.
pre-assessing patients, they're those stupid MABs, and they say the name, and you're like, what the hell did
they
they
cost
say?
a fortune, don't they?
They do. Some of them do. Again, they're getting cheaper with the advent of biosimilars. IBD drug pipeline is one of the busiest in all specialities. There are always new drugs on the horizon, which is fantastic for our patients, especially the ones that are coming towards the end of medical therapy. And what that means is we've exhausted every biologic that we can with them. And at that point, we're saying, okay, I think you probably need to come to our joint clinic to speak to, you know, Mr. Shaw or Mr. Klimovsky, potentially about having surgery on your bowel. And then we have some that we kind of, it's almost like we limp them until the next biologic is available, because we know we've got X, Y, and Z potentially come in, waiting to be licensed, has gone through all trials. If our CCG will give it to us with funding and things, we're very lucky here, to be fair, with our CCG. A lot of other CCGs are very tight and they won't let patients have these drugs, and they have to be in a specific order. And sometimes they say they can try 2 and then it's surgery. With us, we're a lot. We will go through all of them if that's what the patient wants, as long as they're aware that their likelihood of responding kind of goes down, which is, yeah, it's difficult.
So that's what I said about admit and monitor acutely unwell patients, along with the doctors. Also treatment planning, Sophia said, we have got a ladder, which I'm going to show you later. We start off at the bottom, we have got a ladder of treatment that we follow, sort of to risk and cost as well. So with the formularies, we have to stick to that. and management of side effects. So, which is a whole can of worms. So, although we deal with IBD, we get a lot of upper GI symptoms with patients that want omeprazole or have a host of other symptoms, nausea, vomiting.
A lot of our drugs can be fairly side effect inducing. A lot of them are, and they get butted back to us from the GPs because they've got a rash on their leg. And they say, oh, GP said my pentaser's causing that rash. And I'm like, oh, it's absolutely not. Or, you know, my toe's gone necrotic and fallen off. They reckon it's my biologics. I'm like, probably not. But so we get a whole host of other things. That there's a lot of filtering, to be honest. And it's really hard to say to the patient, do you know what? I'm fairly sure this is nothing to do with your IBD or your medications. You're going to need to go back to the GP to that. Oh, and I've spent 2 hours on hold to them, and it's really difficult. But yeah. So,
And that's the
that's the clinics, is it?
yeah
Telephone clinics.
the
helpline.
That was it. So
Bane of our lives.
we got the mobile phone that we have patients ring up for queries. We try to answer it. Well, no, we try not to answer it, but we let go to messaging, and then we pick up
So they
messages
leave a
twice a day.
voicemail. We ask them specific questions because otherwise it rings 10 times a day.
Yeah. And also the IBD mailbox that we have just constantly coming in messages.
Yeah, which is great for younger patients. They love it. They're at work. They can just, or they're on their sofa. They can just write an email to us, send it off.
Who monitors that? Is it
Both of us,
How do
and
you manage this?
well, about 250 to 300 a month is what we're getting in inquiries from patients. We try our best to respond to them within 48 hours, but there is some triage involved in that as well. If we're incredibly busy, unfortunately, the ones that are, you know, less pertinent or less urgent are going to get pushed to the bottom. We'll get back to them in due course. So, you know, you're also fighting a tide sometimes of frustrated patients because there aren't enough hours in the day to get back to them sometimes. Bless them.
Oh, how do I go back? Sorry.
On the left, you scroll up.
There we go.
So this is the British Society of Gastroenterology guidelines for new IBD referrals. It says from 16 to 40, but it's actually probably all of our patients.
So this is what, when we were talking about GPs, this is really, you know, this is the algorithm that if they get someone presenting, this is what potentially they should be thinking about. So we thought that this was, you know, again, it's relevant to you guys because you see this bit here, and then as they get to endoscopy for their
rectal bleeding, abdominal pain, change in bowel habit, weight loss, iron deficiency, anemia. So it just follow the algorithm and sort of refer to gastroenterology.
But the amount of patients you talk to on the phone, now, even before we did the phone, you say to them, have you got any bowel disease? And they say, oh, yeah, I've got irritable bowel disease. I said, oh, so you've had a colonoscopy? No, how do you know you've got irritable bowel disease? My GP told me.
Yeah.
great point.
So
Great point.
much.
Yeah.
And I always say there's only one way to diagnose it, and that's on biopsy.
And actually, a lot of our patients, when we have new patient appointments with them, they say, oh, so I've got IBS and IBD. And I say, no, you've got IBD. Now, with patients with IBD, you can, in very rare circumstances, have what we call a functional crossover. So there is an IBS component to them. But as IBD nurses, we are always going to look for IBD pathology before we say, I think that this is maybe a bit of IBS. And, you know, we will go in deep to prove that there's no inflammation, because that's a dangerous game. If you're telling them, you know, no, I think there's just a bit of IBS, take some Buscopan, you'll be fine. So very few of them. And we say, no, there's probably the IBD the whole time giving you these IBS symptoms. And they are very similar. They can be very similar.
We just wanted to ask the question, what does an IBD patient look like to you? Is there any sort
Some
of
of them, you've only got to look at them too. They've got colitis.
yeah? What sort of thing
They're
would you
very
be?
pale, very thin, they look ill. You can tell the minute they
A bit like that.
Exactly. And this is the picture that a lot of people think of when you say Crohn's. to someone or colitis. This chap's obviously got an ileostomy here. Is this picture of malnourishment? I mean, you as nurses, you would look at that patient and say you're not well. However, on the other side of that, I have probably just as many patients that are malnourished that are struggling to lose weight. We've got quite a lot of obese patients on our caseload. That doesn't mean that they're not going to toilet 20 times a day and they're not in incredible pain. And actually, IBD is the epitome of silent disease for most patients. You won't ever know. A lot of them won't ever tell their friends. I had a patient last week. She's had an ileostomy for her Crohn's for 16 years. And her best friend's husband was diagnosed with bowel cancer and needed a right hemi and an ileostomy. And he was freaking out about it. And she went there and she said, and he nearly fell to the floor because he did not have any idea that she had an ileostomy for 16 years. So it is, you know, and I make a point of never saying to my patients when they walk into my clinic, you look well. Because just because someone's put some mascara on and done their hair does not mean that they feel well. They may well have dragged their legs like concrete to that appointment, you know, and had to stop 20 times to go to toilet in the meantime. So it is a tale of two cities. You get the very obviously unwell patients and the ones that present as fairly well perfused, pink and healthy, yet you put a scope in them and go, oh,
I was going to say, I see so many patients actually that look really well, but
exactly.
Their disease looks really quite
exactly. So
substantial.
they compensate, and you just can't see it.
We call them the silent patients because they're really hard to persuade to have that treatment because they're like, I feel fine and I've got no symptoms. And like, actually,
Yeah, so they're the ones that are totally asymptomatic, predominantly Crohn's, where you go, okay, we've done this colonoscopy and you've got, you know, you've got some nasty aphthous ulcers, I've done an MRI, you've got fistulating disease in your small bowel, and they say, get out of town. There's nothing wrong with me. What are you talking about? They're the minority, but they are there. They're quite difficult to counsel on these drugs when we say, okay, there's X risk of cancer, there's X risk of, you know, opportunistic infections, and they go, I'm all right with what I've got, thanks. They're trying to tell them that they will get ill at some point. It's quite difficult. This is the treatment ladder that Sarah was talking about. I'll let you run through that.
so we start sort of at the bottom. So if patients come into endoscopy, they're likely to start off with either oral or rectal mesallicines, either Salafork, either top down or bottom up. Yeah. These are the granules. These are haven't got any medicine in, but you can try the taste. Do you want to pass those?
How do you make that up then?
How would they literally just
the granules?
Oh, okay.
Pop them onto your tongue. They're lemony. This is budesonide. You've probably seen it prescribed on outcome, you know, from endoscopy. Some of the endoscopists will prescribe budesonide for patients. You got the fun squeezy thing.
Oh.
No, that's all right. We did have some enemas and things like that. Yeah. Open them up. There's no active medicine in them. They're literally. So they would have these for 12 weeks, once a day. They'd be necking that onto their tongue.
Like bit down.
Yeah, exactly. And down they go. And there you go. That's one form of steroid. Prednisolone, on the other hand, anyone that's ever had prednisolone will know that they're tiny little super bitter, horrible tasting tablets. And they start on 8 a day when they come out of here with a new diagnosis if they're bad.
From there up,
I'm enjoying my first cup of tea.
Exactly.
So there on up, we do immunosuppressants such as azathioprine and mercaptopurine. They come along with a host of nasty side effects and increased risk of cancers. And then to biologics. So that's where I come in. Which are mostly injectables, or they have you go to the infusion unit at Eastbourne, they have your, obviously we used to have McCartney here, but it's no longer here.
It's so good that you can inject them now, because it saves people going there like several times a week, but their life is more.
Yeah, so these come in an injectable pen, a bit like an insulin pen. Again, I'll pass them around. They're delivered by healthcare at home, stored in the fridge, and again, how much for one of these? pens worth? 100 and...
Yeah, those ones are about £210 per injection, so not too bad, but they're having 2 a month of those.
How often do they inject?
That's
Fortnightly.
fortnightly, so that's
They have 4 to start
this
with.
one's more expensive. That one's about £800 per injection. This is vedolizumab. They're all subcut injections, so they're all made for patients to be able to give them at home. Like I say, they're auto-injector pens, and they're designed for people that don't have much dexterity, so they can stab and go pretty much. You know, you put it in your leg, dunk, hold it down. But we have lovely home care nurses that go out to teach. They go into their home and they teach them how to use it. They'll supervise them, and they'll keep going back until the patient is confident that they can do it themselves. Even needle phobic patients, you know, I say, look, I guarantee you there's someone in your life that will want to stab you with a needle once a fortnight. And everyone always goes, yeah, there probably is. So, you know, they're fairly well tolerated. That one, the Imraldi, the green one, stings. It is horrible. Patients, yeah, like a bee sting, and patients will tell you, hit the roof.
Citric acid in it, so that's
Yeah, there's a carrier that really, really is stingy. So a lot of them have to work themselves up to do it.
Yeah.
Get some
That's
help.
a shame.
It's the expensive one then. Is there a group of patients?
So that the vedolizumab there, which is the more expensive, again in this triangle here, there's a triangle inside the triangle. So first line, we would try the Imraldi, there, the green one, or infliximab, which is the IV infusion. If they fail that, or if they are contraindicated to that, and to be honest, that would go to MDN, and we'll be thinking about vedolizumab if someone's got a lot of comorbidities. If they're probably over the age of 70, we might have a discussion on it. We still might put them on that. Or if they have a history of heart failure, they cannot go on anti-TNF agents. So at that point, we move them to second line therapy. So, and then there's another one called ustekinumab, which is about the same price of the vedolizumab. And again, that's more used in Crohn's, and we use vedolizumab more in colitis. So it does kind of divide up. And there's more coming.
the top of the triangle is obviously surgery, although if you ask any surgeon, they probably want to, it's not always the last resort. It can be some of our patients come to us beforehand and say, I want surgery, I want part of my bowel removed.
So they're just done with it by that point.
Yeah, they can be in control of their life.
Yeah,
to get through their life back.
Because the trouble with this is, if your life is governed by a toilet, wherever you go,
It
you've
must
got to
affect
make
people's
sure
mental
you've got-
health. Massively.
Yeah.
Oh, yeah.
Hugely.
Yeah.
One
I think
in,
it's one of the worst things because you can't say to a patient, oh yeah, you've got inflammatory bowel disease, but it's all right, after this course of tablets you'll be fine.
No.
They've got that for the rest of their life.
And you don't know when as well, do you?
No,
It can be staying
and it
for
just
ages.
flares up when it thinks it flares.
It's so hard.
it's
I
an
just think it's an
absolute
awful
battering
disease.
emotionally.
Yeah.
One, that the statistics are that 1 in 4 patients with IBD will suffer with depression and anxiety. You know, whether it's cause and effect, we don't know, but it doesn't take a rocket scientist to work out. What I say to my patients is, but rather than saying, how many times a day are you opening your bowels? I'm going to do all of that stuff because that's how I need to assess them. We ask, how is it affecting you? A question that I always ask my patients, if you're going out for the day, do you have to find out where the nearest public toilets are before you even think about going there? And if they say yes, then it is having a huge effect, to the point where a lot of some patients will become quite severely agoraphobic. They cannot leave the house because they are terrified that they're going to have, you know,
There's such a taboo
soiling
around it,
yourself
isn't
in
there?
public
You know.
is one of the most mortifying things, I think, for a lot of people. You know, that is
I don't know, I do it all the time.
any age. And you know, when my patients say I have to wear pads, you know, I'm like,
Particularly young,
"Oh."
young people as well.
Counseling must be a big part of your role as well, isn't it? It's more of, you know.
Is we could do with more. So if anyone wants to train we would love a cognitive behavioural therapist with our teams. If anyone fancies doing their training, please let us know. Stephen, start the business case. All right.
There's not a counselling group or
Yes,
anything.
yeah.
We should
That
have.
would help.
You know,
Okay.
IA meeting, like where people can go.
Yeah.
We were about to start some patient interaction forums and
And
then
we would
COVID
love to
hit.
join that, yeah, to help you.
Yeah.
Yeah.
So unfortunately, COVID hit. That all got put on the back burner, but it's something that
Yeah.
you know we really want to do.
It's
So
great
but-
if people can meet up and
Mm.
talk as a group, like, yeah, so they've got
But
that.
also, if you can talk to other patients that are going to somebody else who's going through exactly the same as you are,
Yeah.
Mm.
it's all very well for us to sit and say, oh yeah, I know,
Yeah.
but we don't
No,
know.
No,
because we've
no, no.
not
Like
been
a
there.
focus group is, you know, we do that here for
Yeah.
endoscopy.
Brilliant.
Yeah.
They work wonderfully.
Maybe one day, that's what we're going to do, isn't it? Purely for IBD. Yeah.
There are
That'd be
patient
good.
forums, but it's a bit like TripAdvisor. You only patients put on the worst case scenarios. I think sometimes it can be a bad thing. So we always try and post our patients to Crohn's and Colitis UK for it's a more sort of realistic, positive.
And we're really
It doesn't-
happy for
don't
you
just
to
get
say
negative.
to patients if their new diagnosis we're not around, have a look at Crohn's colitis UK.
Yeah.
You know.
So if I'm being honest, that's one of the things, that's one of the reasons why we lured you to do this presentation. You know, when we get newly diagnosed patients, you know, after having
Yeah.
been scoped, we will be the first point of contact in a sense, isn't it? Yeah, thank you.
So, what role can you guys play? So, dietary advice. A lot of patients, I should imagine, saying, "What can I eat? I don't know what I can eat." We recommend a low residue diet, which
If
we
you've got
get some-
diarrhea, not
Yeah.
if you're constipated.
I can get some of these copied.
Please,
All of these
yeah.
materials will be in our office, so please help yourself. I'll show you. They all what's come in, so I don't know what they are.
Sorry to interrupt you. Is
Yeah.
that dependent on biopsy results, or is it because it's been seen and it's on the report that?
So if they are suffering and they're opening their bowels multiple times a day, we say it's actually a low fibre diet. So the way I describe that to patients is imagine what your toddler would want to eat. We're talking mashed potato, pasta, chicken, fish, those type of things. White rice, no sauces, no richness. And for the first couple of days, people are like, yeah, chicken nuggets and mashed potato. And then it quickly gets boring for them, okay? Like my 6-year-old would happily live on that. But for an adult, and I always say to patients, because I've got patients that end up on a low fibre diet for years and their hair starts falling out, they're not getting any B12, they're terrified. And that's also another, you get these cyclical eating patterns with IBD patients, and a lot of them can end up with avoidant behaviour around food because they are trapped in this cycle of either food equals diarrhea equals urgency, or food equals crippling pain if they're Crohn's, so they start avoiding things, and that's when you see them really slim down.
Okay,
And that's why Brian, our dietitian, again, we need a therapist and we need a full-time IBD dietetic. It's a really important. If 30 years ago you had said to any physician or gastroenterologist, I think that the diet plays a role in IBD, you would have been burnt at the stake for witchcraft. They would have said to you, no, don't really think that that's got anything to do with it. But some more studies are coming out now. But the problem is, for every diet that you see on Crohn's, I guarantee you there will be another one that is the total opposite. But it's a minefield out there. So we really like patients to have dietetic input with that.
I'm conscious of the time, and I will just
Yeah.
try and wrap up quickly. So information booklets, again, these are all in our office. Crohn's and Colitis UK. There's a food guide, one on colitis, Crohn's.
And we've just ordered some
And
more.
we
so
have
you
we
can
have a
them.
lot, yeah.
Yeah,
Okay.
yeah.
We've just ordered some more. Obviously, signpost again to Crohn's and Colitis UK. You can ask us to come out and speak to patients if they're very anxious, or just I've got lots of questions. If you're around, we're more than happy
Yeah.
to come and ask and reassurance. Just try and let's just in their role as it is. So
Yeah.
just try and give them as much reassurance. We have contact cards. Again, they're not really supposed to hit our books until the biopsy results have come back, but we're more than happy to to contact somebody if they've got questions.
Yeah.
And if it's 90%, like, yeah, this looks like a life
You know, you
system.
get those patients that it's like, it's black and white IBD. There's nothing else really that it could be. Those ones that, you know, milder edema, maybe one abscess ulcer, I would discourage you from giving fluid alcohol until we get biopsy results back. But if you're looking at a politic that is, you know, rip-roaring disease, then by all means, you know, please. And you're brilliant at letting us know anyway. I know reports come to my desk, and what I do is I check them back every week to see if the biopsy results are back, and when they are, I book them into my clinic.
I have whizzed past, I did put a clip on there, I don't know if anybody saw the BBC Strictly Amy, Me and My Crohn's. It's a really good watch. There was a clip on there from a girl who sadly passed away from sepsis. She'd
We
been
got a couple
diagnosed.
of minutes?
How long is that?
2 minutes?
Are we okay?
Yeah.
Okay.
It's a really good program. It's on iPlayer at the moment.
I think
Just more, you know, kind of gives you another sort of insight into the day-to-day life of a crony or a colitic lesson.
Hi everyone, my name is Bethan and I have Crohn's disease.
Bethan James, a 21-year-old student, first realised something was wrong in spring 2019.
I just really personally just want to get the word out there about Crohn's because you'd be surprised actually how many people do have it. So yeah, that is just my main aim.
Bethan had wanted to be part of this film, but it wasn't to be. In February, she fell ill and died from sepsis with possible Crohn's-related complications. Her parents, Jane and Steve James, hope her message can live on.
But this is sort of trying to Beth.
I don't know, it's just nice to have a place to sit and think about that.
Think about Beth, yeah.
Sit there in the evening with the bit lit up with hot chocolate and favourite. Yeah, we sit there and think about her.
Bethan contacted me on social media shortly after she was diagnosed. So your lovely Bethan, it was about a year ago, sent me a message on Instagram, and she was wanting to raise awareness, and she was so positive.
It was inspiring for her, and to see what you achieved with dancing and Strictly, and it definitely made her stronger, and it made her think that she could go on and achieve what she wanted to do.
So what was Bethan's first symptoms?
So it was in May of last year where she started getting really bad stomach pains. And she, every time she tried to eat something, she was in considerable pain. We'd be at the dining table at meal times, and she'd sort of be bent over in pain as she was trying to get some food down. She was diagnosed then in August of last year, just before her 21st birthday.
In the lead up to her death, Bethan had severe breathlessness. She visited A&E 5 times in 10 days. But her condition went downhill rapidly.
Crohn's is inflammatory, isn't it? So the inflammation was just increasing within her body, and she eventually died of sepsis. For all to happen so quickly is just so.
I think that gives you the.
No, I think the take-home message there is that Crohn's and colitis isn't just diarrhea. You know, it's rare. It's getting rarer, but it does happen, and people lose their lives to this condition. So when someone goes, oh yeah, I had a bit of dodgy tummy last week. It's a lifetime. I'm never knowing. And what I say to patients is, I really hope that I can get it off your shoulder. They're looking at you the whole time and in your shadows. But that's the best that we can do, is that it's in your shadows, and you are aware it's there from time to time. And that's what I hope for you, is that you don't have to be living with it all the time. And that's the best that we can do until we have some kind of cure, which is a long way off.
And a more simple way of managing them, isn't it? But at the moment.
Exactly. But the work you guys do are great. And actually, from us, feedback to you guys, our patients, I know that probably a lot of our patients are quite expert when they come in for endoscopy, because they've had 7 of them beforehand, and they know exactly what works for them and what doesn't. And the other side is that obviously you get quite anxious ones that may have had really bad
Yes,
experiences
yeah.
before, because it's raw when
Yeah,
so that was a
that's
whistle
it,
stop tour.
Yeah.
I'm sorry.
Thank you so much. Very good, very good.
Yeah, thanks for listening. Any questions? Our door is always open, apart from when it's locked when Judy's changing.
Yeah.
Apart from that, yeah, come and ask us anything.
Yeah, but equally, if there's anything that we can do for you as well, you know, we work as a team and not having
It's a lovely
you.
atmosphere.
Yeah, of course we do.
Yesterday, I was admitting a patient, young one. I showed you the referral.
Yes.
She had the RTS procedure
Yeah.
and ileostomy formation.
Yes.
And when I was free, she said she's very, very anxious towards her stomach, so she can't change her stomach. Her husband is always the one doing the stomach because of anxiety. So I thought, oh, how old is she?
Yeah. I mean, that particular patient is incredibly complex as well. Not just with the Crohn's, with other stuff. The procedure wasn't actually for her Crohn's, but anxiety is a huge issue. And actually, I had a patient the other day, joint pain. No one thinks of this. Joint pain is a big symptom of IBD. Any autoimmune condition, joint pain. And I've got a patient whose joints have now got so bad she can't change her stoma, and she's looking at a 12-week wait, and she was in tears because she's like, I don't have the dexterity to try and pull the ring off to change my stoma properly. I'm in so much pain, but no one can give me any joint injections, you know. So it's just all these little things that you're trying to problem solve the whole time. And yeah, never know, might be some future IBD nurses in here. And when we get this huge service, steal them from you, Maya. And thank you so much. And like I say, anything that comes to mind, our door's always open. We're always really happy. If anyone wants to come and sit in on our face-to-face clinics, then please do. Our joint surgical one's quite a fun one as well, because you've got me and Mr. Shaw sort of batting off each other. I'm like for saving the bowels, he's for chopping the bowels out, and we give the patient, our idea, and then let them make their own choice on that. So
What days do you do clinic on?
Thursday is
And you're
first
happy for
afternoon
us
face to face.
An afternoon? Is it afternoon? Oh, perfect for us.
And our NDM is on a Thursday at 1 p.m. as well.
More stuff in the afternoon, so we can probably rotate.
Yeah, you do referrals as well.
Yes, yeah, I do. We do.
Okay, thank you very much.
Thank
Thanks
you.
so
Thanks
much.
for having
Dr.
us,
Paul,
guys.
any words? Anything you want to say? Probably gone now.
You still awake?
Thanks, guys. You guys have been fantastic, and that was a really good session. I'm really, really grateful.
No problem.
Thank you. Thanks, everyone. Thanks, Naren.
Thank you. Yes, thank you.
Someone else that joined us earlier.
Bye, bye, bye.
Bye. Bye.
Hi, Elise. I can't remember whether we're doing. Are we doing our catch up through this one? I never remembered which way we were doing this.
Well, I think this is probably the best way to do it. Sorry about that this morning. It sounded like it was a really good session, but I'm